sometimes. All right, everybody, welcome to Hormones 101 with me, your host, Hayley Foster, and the amazing Dr. Anita Sadaty. We did one of these a couple of months ago, and it was great. I learned so much, and everybody that came learned so much, and the feedback was amazing. We decided to do it again. So here we are, and thank you all for joining. I do have some questions that some of you submitted. We have a little bit of a presentation we're going to take you through as well. But first and foremost, let me just introduce you to our co-host. Many of you are here because she's here, not because I'm here.
I don't know about that.
True, it's true. So I'm excited that we have Dr. Anita Sadaty here. She's a board certified OBGYN and integrative medicine practitioner. She is my doctor. And she provides, and I can tell you this firsthand, individualized, personalized medical care that really focuses on discovering the underlying issues behind some of the things that make us not feel well. So with that, I will go ahead and kick off tonight. Again, please just make sure your microphones are muted. We are recording, so if you're watching this on the replay, thank you for joining on the replay. We got a lot of questions, but I think one of the best places for us to really start is, last time, if you haven't seen the last video, let me know and I can send you the link to that. We really broke down some of the misconceptions behind menopause. And I'm very out there in terms of my own menopause journey and the hormone replacement therapy that I am on. And I put it out there to friends and just to people in general. And a lot of people come to me and ask me for advice, which sort of prompted the first one, and asking, about all of the things. And so what we wanted to really do tonight is really just to break down for you the different stages of a woman's life from the reproductive years to postmenopause. And what we're going to do is we're going to break that down into what are some of the symptoms that you might be having at these different stages. And I'm excited because I know a lot of people that are on here tonight. I'm excited that there's women on here that are in their 30s all the way up to women that are over 60. So thank you all for coming, and we are going to dive into it. I'm going to switch over to the presentation so that you can follow along. Give me 1 second. I just realized I'm on the last page of it. Hang on. Start here. Okay. I'm going to share my screen. And share. Dr. Sadaty, before we get into this, do you have anything that you wanted to add?
No, I think you covered it. Our part one was definitely about dispelling the misconceptions around hormone replacement therapy and the purported risks. And that focuses a lot more on women who are in menopause. This time around, we want to sort of give patients or people a primer on what are the different imbalances that you might be experiencing in the different decades of reproductive life, and how would you specifically look into targeting the underlying causes behind those hormonal imbalances. So I think this is much more kind of specific to symptoms, age, and also just what do you do? Like what specific, right, or what would I recommend that you do, let's say, if you came to me as a practitioner. So yeah, so happy to get started.
Okay, great. And I do want to just put the disclaimer out there, which is really your disclaimer, that this is not medical advice. Yeah. This is really us just having a conversation, and all of you are kind of like peeping Toms in on the conversation.
All about the education
for tonight. Yes, it's education. This is not medical advice. So just putting that out there. One of the things I really want to just kick off with, I think that, and I know you will agree with this, but the biggest things that people can start doing, and I guess you could disagree if you do, but the biggest things that people can start doing are really diet and exercise and sleep. I would say when people say to me, like, they're not feeling good, like, I've been doing a lot of my own longevity journey and health journey for years now. And the three biggest things that have had an impact on my own life have been those three things, and really getting a handle on sleep. I use my Aura ring for that. And really getting a handle on what sort of exercise I should be doing at this stage of my life. We may not agree on that. And then in terms of diet, really like what kind of diets to follow. And I know that those aren't all necessarily in your wheelhouse, but I think that you would agree that those three things are really key to helping people to really start feeling better than they might already be feeling.
No, I agree 100%. I consider there to be four pillars of health, three of which you've just mentioned. One is all about your diet and your nutrition. Are you eating to nourish yourself? Are you eating to reduce inflammation in your body as much as possible? Two is sleep. You have to get restorative, adequate, deep sleep in order for anything to function well hormonally. Exercise, doing the right kind of exercise for where you are, making sure to listen to your body. It's not the same for every decade, for sure, and for every hormone state. And then the last pillar is
or for every cycle, right? Every stage of the cycle.
Exactly. There's differences
right.
there as well. And then the last pillar is, of course, your stress hormone balance. It goes without saying that you can do whatever kind of hormone treatment you want. If those things are not dialed in, you're just not going to get the most bang for your buck. You're not going to get the health benefit that you think you're going to get from hormone replacement therapy. So hormones do a lot, but they can't undo a terrible diet. They can't undo only getting 5 hours of sleep. They can't undo a completely sedentary exercise existence, or the opposite, completely overtraining and depleting yourself. So it goes really hand in hand. So we're going to talk a little bit about that, certainly through the stages as well.
Right. And I'm so glad you mentioned that, because that I put my hand up here. Like, I'm so guilty of overtraining for years and not knowing how detrimental that was on my hormones. And until I did a Dutch test and wore a glucose monitor, I really didn't understand the impact that that was having on me. And, I can't undo those years of killing myself and, operating at that intense high level. But I'm certainly making up for it now and brought it down to a much calmer level. So thank you for that. Okay. The reproductive years.
Yeah. So here we go. So I'm gonna dive into what most people can experience as hormonal imbalance in the 20s and 30s. This really relates to struggles around your period, whether that's irregular cycles, incredibly painful, heavy cycles, bleeding between cycles, luteal phase, or the 2 weeks before your period, experiencing severe PMS or PMDD related symptoms like mood instability, anxiety, depression, fatigue, breast tenderness, bloating, constipation or diarrhea, those energy level changes. So those are, for the most part, what you can experience. Infertility, certainly, recurrent ovarian cysts or ovarian cyst rupture, fibrocystic breast disease. I mean, the list goes on. You can say that there's a million symptoms that you may experience in your 20s and 30s. And those all relate to how your estrogen or progesterone levels are with respect to each other. Are they in balance, or are they excessive or depleted in certain scenarios? So the thing that and again, Hayley, you really kind of stole the show with your opening line, is that the hormones are really a symptom of an underlying problem. So it's not that your ovaries don't know how to make hormones at this age. That's not what's happening. The signal to the ovary could be abnormal. The production can be abnormal. The processing of the hormone can be abnormal. The way the receptor responds to the hormones can be abnormal. But all that is predicated on four basic systems in your body. And those four symptoms are: what is your blood sugar and insulin level? What is your stress hormone level? How does your gut work? And what is your food? What are your food intolerances and food sensitivities? And what is your inflammatory or toxic burden? All of those things are what translate your hormones into symptoms that are problems. So even though we think of like giving hormones or managing hormones as the underlying problem, it's not. These other things have to be balanced in order for you to produce, process, metabolize, eliminate your hormones in the right way. So when we say optimize overall health, this is exactly kind of like what we're talking about. So, and that's different for everybody. And that's really different for everybody. But I will say that when women start to balance their blood sugar by eating enough protein, minimizing processed carbs, watching their sugar intake and their alcohol, which, as you know, I don't think anyone's made more of a 180 than you, in terms of the
Clearly.
alcohol conversation. Getting enough sleep. I mean, I can't tell you how much, just for example, having somebody go gluten and dairy free, reduce their processed foods, eat more vegetables, like how much that changes hormones, or making sure that they're pooping every day and eliminating hormones that are accumulating in their body, or getting enough sleep, or not drinking caffeine, which will disrupt your sleep. Like all of these things are going to really affect the female hormones. So in this stage of the game, it's women are very responsive to lifestyle changes. That's where you
Right.
really can make an impact, and you don't even necessarily have to add hormones into the mix here. Just
Right.
kind of exciting,
And I mean, how often do you test women that are in their 20s that are coming in with those symptoms? Is it something that is
So
like a normal type of thing?
they're very common, and what the hormone testing that you want to get at this point is really luteal phase testing. So luteal phase means after you ovulate, the period between when you ovulate, which is the middle of the cycle, and then when you get your period. So that's when you're producing the most hormones, the most estrogen, the most progesterone. And that's a good time to measure estrogen and progesterone levels, among other things. Do you want to check thyroid? Yeah. Do you want to check nutrient imbalance? Yes. Do you want to look at vitamin deficiencies? Yes. Do you want to look at, autoimmune factors? Yeah. I mean, I'd love to look at all of that. But if you're really just sort of wanting to know, is my estrogen and my progesterone out of whack, then measuring your hormones a week before you're due for your period is when you want to see whether or not your estrogen is in range and whether or not your progesterone is in range. Now, specifically in range for someone in their 20s and 30s, estrogen should be somewhere between 100 and 200 on serum levels, like picograms per milliliter. And then progesterone ideally should be between 15 and 25. So those are the numbers you're looking for. And so it's a little bit of a guideline, but you also want to make sure that they're balanced. That your estrogen's not too high relative to your progesterone, or progesterone's not too low relative to your estrogen. That's typically what we talk about when we say estrogen dominance in the 20s and 30s, which of course carries into the 40s as well. But estrogen dominance seems to be the problem that most women struggle with. There's way too much estrogen relative to progesterone. Now, that could mean that you're making too much estrogen, or that you're not eliminating enough estrogen, or you're not processing your estrogen well, or you have too many endocrine disrupting chemicals that mimic estrogen, or it could mean you're not making enough progesterone. So it's important to get the absolute numbers, but the relative amounts are kind of what creates symptom.
And just speaking from my own experience, I know that at that stage, there are things to do other than going on a progesterone or an estrogen or having testosterone at those ages, in terms of there's supplements that you can take in order to like get your adrenals working better. Cause I know that I was on, an adrenal supplement and a DIM supplement. We could
Mm-hmm.
talk about some of those supplements later.
Mm-hmm.
But there are things that you could do at those ages that don't necessarily mean you have to start taking hormones.
Well, I mean, you're 100% right. And you can correct what the underlying cause of the hormonal imbalance is. The issue is that most people, it takes time, energy, effort. It's not easy. You have to investigate, you have to change your lifestyle, you have to do things that are more difficult in our society. It's not easy to eat well. It's not easy to get sleep and get off the devices. It's not necessarily easy to dial in your exercise the way you need it to be. Change a job that's killing you. I mean, these are not easy asks.
Mm-hmm.
But I mean, I'll give you an interesting example. I have a patient who's in her early 30s, and she has polycystic ovarian syndrome, irregular periods, and she has done a lot of things to get healthier. She sleeps, she does yoga, she's gluten and dairy free, she minimizes processed foods, she's very careful. She eats a very healthy diet, and I have her on a couple of supplements to help her get a more regular period. Just so you guys have heard it, one is called Sensitol, which is basically a combination of myo-inositol and D-chiroinositol. Both of these specialized B vitamins have been shown in studies to improve ovarian quality and ovulation. So that's something that can help you regulate your period. And I have her on a liver detox formula and a gut support formula called DIM Detox, which just helps your liver process out excess estrogen and create a more balanced estrogen progesterone. Okay, here's the thing. She's great on it, but when she stops it, she goes back to her problem. And why is that? Because we haven't gotten to her underlying cause. Her underlying cause is not her diet right now. It's not her exercise. It's not her stress levels. It's none of that. It's something else. And that's what I said to her. I said, you have bloating, you have gut issues, you have mild IBS. We have not investigated that. That is why you have this hormone problem. You're going to have to deal with that at some point. And she's like, you're right. She knows. So, she wants to get off of those supplements as well, even though they're natural and they're helping her and they're correcting her problem. We're still not getting to her real issue. So,
yep. The root cause.
Yeah. Root cause.
Yeah. Excellent. Well, thank you for that. We're going to move to the perimenopause years.
Perimenopause is my favorite. Because every day of every week is different.
Right. I was like, said no one ever.
Right. Yeah, it is. It's rough. The perimenopause, which essentially is about 10 years or more before you are in menopause, which is the whole cessation of periods. It's tough. You go from making too much estrogen, too little estrogen, too little progesterone, not enough testosterone, too much testosterone, too much insulin, not enough. I mean, it's a free-for-all, and every cycle can be different from the other. So this is where you get the convergence of ovarian quality diminishing. So the eggs that are still around are not necessarily quality eggs. So the ability for those follicles to then generate normal hormones, either they don't ovulate or even after ovulation, the production of progesterone and estrogen is not balanced. So just by virtue of aging, you have that issue. But then you lay that over now 40 years of stress or not eating right or not sleeping well or having some kind of gut imbalance or having a toxic exposure or a chronic viral or Lyme infection. Like, you've accumulated sort of stuff that is now making things rougher for your body to navigate. So that combination is super complex. Having said that, the basic pillars always have to be corrected. Like we said, the diet, the lifestyle, the stress, the sleep. Definitely alcohol, you really need to consider eliminating a lot of it because that's just not helpful. But here is where supplementation and hormone balancing can be very helpful and may be necessary, as opposed to, I think, in your 20s and 30s, where correcting those underlying imbalances can by itself kind of fix the problem. So here is where women experience the gamut of estrogen deficiency, estrogen excess, and progesterone deficiency and testosterone deficiency. Those are the 4 ways in which the hormones kind of become imbalanced. So we can have estrogen dominance, and we're going to go through those symptoms, and you can have estrogen deficiency. And it depends on where are you in the month, and it depends on what cycle. So that's where it gets super tricky. But overall, perimenopause is usually where you're not making enough progesterone to support a normal cycle. And you're usually making too much estrogen relative to progesterone, or you're not processing your estrogen enough and you start feeling excess estrogen symptoms.
Right.
So,
and we're going to talk about different tests that you can run in order to find out what those levels are and how your body is processing them.
And that's a good point, because a single blood test is really difficult in this stage because periods start becoming more irregular and erratic. So it's hard to figure out that day 21, that week before your period is coming. That's harder to find. The other thing is that this month may be very different than next month, which was different than the month before.
It's a roller coaster.
It's a roller coaster. It's a great word for it. Yeah.
It is. And one of the things that I hear a lot from people is, well, I went to my doctor, he did a blood test or she did a blood test, and they don't think that I should go on any type of hormone therapy.
Mm-hmm. Yeah. I mean, we're taught as conventional, gynecologists that, first of all, there's still such a stigma in terms of even allowing women to consider hormone replacement therapy, and the catchphrase is still use the lowest amount for the shortest amount of time. That's, basically just try to treat the symptoms for a short amount of time to get through it and then stop, without, considering that there are long-term benefits of hormone replacement therapy, compared to the risks. But at any rate, let's talk about what you just mentioned, which is if you're in perimenopause and your doctor essentially says you're not a candidate for hormones, yet they're very happy to put you on a birth control pill. Well, what do you think that is? That's high doses of synthetic foreign hormones. So they're happy to put you on that. And what is that doing? That's shutting down your system, preventing your pituitary from communicating with your ovary, telling it what to do. You now have lost any sense of what your body is doing and what your body needs. You have no idea, because now you're just on the fake hormones. And yes, it will quiet the symptoms. It will take it away, but it's not taking away the problem, which continues to brew and manifest, even though you don't know it. It's like we literally just covered up the check engine light because we don't want to look at it. So, here is where I think hormone balancing is very helpful. And this is great. So these symptoms: too much estrogen, the waking, the water retention, the bloating, changes in your quality of period, worsening PMS, worsening fatigue, worsening fibroids, endometriosis, breast tenderness or breast cysts and lumps, reduced sex drive, mood, irritability. These are all high estrogen symptoms. So how do we, and high estrogen can mean either you're making normal estrogen, but your progesterone's too low, or you're not getting rid of your estrogen correctly. So it's accumulating and it's higher than it should be. Those are the two reasons: either not enough progesterone and normal estrogen, or not processing your hormones well and they're staying around in your body too long. So for patients that are not necessarily so into doing like the nutrition, the lifestyle, the exercise, like looking deeper, the quick and dirty way to address this is to help your liver process your estrogens out faster. And that's where a DIM liver support product comes in handy. And adding bioidentical progesterone in the luteal phase in the second half of your cycle to support a normal progesterone level. It's very helpful to fix your symptoms in a way that's at least addressing your problem. It's addressing the issue. It's not necessarily solving the underlying problem, because why is your liver not processing it well? Well, maybe you're drinking too much. Maybe you're on a million medications, and so your liver's like so busy trying to detoxify the medications or the over-the-counter stuff. It could be because you're chronically constipated or you have gut issues, so you're not able to get rid of your hormones well. So it's helpful to think about, well, why am I not processing my hormones well? Like, what is happening? But those two things, just some progesterone and some liver support, like a DIM detox product from Pure Encapsulations, I want to tell you that specifically is the product that I love. Specifically, I order it by the gallons in my office because I give it a lot and patients come back for it a lot. So I know it works. When you come back, it means it works. So those two can be very helpful. But in addition to this, this is where you might want to check a Dutch test. This is where you want to maybe check to see how your adrenals are and how your hormones are being processed. It's a special urine test. It's a 4-point adrenal test that also looks at how are you processing your hormones. Are you breaking them down adequately? Are you breaking them down safely? And why? Let's say you're not. Let's say you're accumulating hormones. And why are you? So it gives you so much information in terms of perimenopause. I mean, like it's a really good test for perimenopause because I find adrenal hormone issues are huge. They express a lot in the 40s and 50s. So
we should do, just for fun, we should do a group where everybody does a Dutch test and then we all jump back on here and you could teach us all how to read the numbers on the Dutch test and tell us. That would be really fun.
It'd be awesome. I mean, it's a great
things
test.
We do for fun.
Yeah, right. That's fun.
Let's get a Dutch group together.
I think it's fun.
I think clearly we both think it's fun, which is why we're here. But well, that was actually, I mean, we were going to talk about Dutch tests later as well, but we can talk about them now. And that's really where I started. I started with hormones after doing a Dutch test and seeing how my adrenals were not processing or processing my hormones. And I will say this, back to the alcohol conversation, not demonizing it, but I will say that when I was drinking a lot, even I was drinking clean wine, I would still wake up with night sweats in the middle of the night. And so it, sleep disruption, I'm sweating my ass off. And as soon as I stopped doing that, I never had a night sweat again. And so the other thing I highly recommend are cooling sheets, cooling pillows, which are amazing. And I have a great brand if anybody wants information on them. But we love our cooling sheets and cooling pillows for those of you suffering. Yeah, so helpful. Yeah. I just got a grounding sheet.
Oh, nice.
I had my first night on.
Oh, how was it? Be careful because you could detox really rapidly on those. So.
Oh, really? Oh,
yeah. You should.
Well, then I have my blood test today, so I guess we'll see. Go slow. I'm like laying.
I slept on it all night.
Right. All right. Well, I'll keep that in mind. All right. So people that are having symptoms from not enough estrogen, let's talk about these.
So this is where I think what you mentioned, Hayley, about why shouldn't I necessarily support my hormones if I'm not in menopause. So for women that are starting to experience vaginal dryness, dry skin, depression, no sex drive, painful sex, weight around the middle, insomnia due to hot flashes, night sweats, these are all estrogen deficiency symptoms. So this is something that starts to happen a little closer towards menopause. So in the beginning, you may have more estrogen dominant type problems, either for the reasons that I mentioned, not enough progesterone production, or not processing out your estrogen adequately. But as you get closer to menopause, you start skipping periods. You start having episodes of not enough hormonal production. I absolutely will put patients on estrogen therapy and progesterone in this phase. Like, why wouldn't you? So just as a background, if you're withholding hormone replacement therapy for someone who has not yet been a year out in menopause, which is the classic, sort of teaching, those women have already started to develop some level of cardiovascular disease. Like, you're already creating inflammation in the blood vessels. So to say that you need to wait, and by the way, women who experience hot flashes and night sweats and a lot of vasomotor instability like that, those women have higher rates of heart disease and heart attack, just generally. So if you have somebody who's experiencing that on top of vaginal dryness and depression and low sex drive and weight in the middle, can't lose, then I 100% would put them on low dose hormone therapy, with the understanding that they could at any moment in time start making their own estrogen again. So I have to educate patients about, listen, if you start feeling the estrogen dominant symptoms, water retention, breast tenderness, headache, like all that puffiness, whatever, that means that you're making estrogen again. You may want to take off your patch. It's common sense, right? This month, you're not making estrogen. Next month, you're not making estrogen. Third month, I'm not making estrogen. Guess what? I ovulated. I started making estrogen again. I got a period. I have breast tenderness. I have headache, whatever. Take the patch off and then just monitor and see, how do you feel? Maybe you're going to start making hormones again for the next 3 months. Maybe you won't. Maybe this is 1 month and you went back to your hot flashes and night sweats. Put the patch back on.
Right.
Like, it's a little complicated, but it's common sense. Like, it's not hard. So I don't think you should necessarily wait until you're fully menopausal, especially if you're having severe symptoms, because the symptoms actually correlate with other problems that are going on in your body. So I think it would be great for women to get ahead of it and just treat, understanding that maybe they may need to change their hormones up from time to time. They may need to stop. They may need to add. They may need to stop. They may need to add. That's okay. Just know your body a little bit, and you can play around with it. So,
Right.
and again, the conversation about like having, okay, it's not okay to go on a hormone, but you can go on birth control. How does that even make sense? Like, that's the same, except for worse. It's high dose and it's synthetic and your body doesn't understand it and you're shutting down your system. So right. I don't get it.
Right. And as a woman who went on birth control when I was 17 and didn't come off until I wanted to make babies in my 30s, right? We could talk about all the other issues that I believe tie back to all of those years of being on a synthetic hormone, right? And something that I've lesson learned. But just, one point I want to make is what, you said it's common sense, but a lot of doctors, again, unless you're really an advocate for yourself and you're doing all the research and you're looking into all of these things, like, why the fuck are my breasts, my breast feeling like this week or this month,
right.
as you're going through, there hasn't been so much education out there for people. And again, unless you're really doing the research, like, this checklist is great. And anybody that's on the call tonight or registered for tonight's call, you'll get this checklist so that you can use it as sort of a guide for what's going on with me this month on my perimenopause freaking roller coaster. And you can, and you can follow along on this and do the testing. And so let's talk about Dutch test. So one of the things I'm curious about as we're talking about blood testing and Dutch testing, in my 30s, which I didn't do, and I wish I had done it, but who knew? Um, 20 years ago that I'd really want to know what my numbers were, during my different phases of my
Mhm.
period. But even in perimenopause, and I know that it changes month to month, but is there any advantage to knowing or doing a blood test, which I know seems a little over the top, but I'm a little crazy. Is there an advantage to doing a blood test like every week for the whole month just to see like where my numbers are at?
So that's a good question because, many years ago, there were practitioners who were trying to mimic hormones of your 20s and 30s for when you're in your 60s and 50s, 60s, and beyond. And, that's, I don't think that's desirable. First of all, your body's very different. The reason behind having hormones at such a level in your 20s and 30s, or even in your early 40s, is completely different than for why you would want to have hormone support later. And the risks will start to go up if you try to mimic that. But let's go back to just theoretically, if you were to measure your hormones every week, during a month, let's say that you felt great. Because if you're
Mm-hmm.
measuring your hormones when you weren't feeling so well, I don't know that you'd want to mimic those hormones.
Right,
um,
not mimic them, but understand what levels they're at,
yeah.
right? So
Well,
on a month where I don't feel
the thing
well.
is that there are standards of hormones that we would expect if you're in the normal bell-shaped curve of hormone production in different phases of your menstrual cycle. So we sort of know that. Um, Comparing yourself, like your 50-year-old self to your 30-year-old self, like I'm not sure that that matters because that wouldn't be a goal for us in terms of if we're replacing hormones or balancing hormones. We want you to have that because remember, those hormones are produced with the concept of getting pregnant and maintaining a baby. That's not what we're looking to do. And that level of hormone production puts you at risk for other problems, but there's the risk benefit. There's also what's the gain and what's the loss. Like, so what you're doing with your hormones at a different stage of your life, it doesn't translate to what we want to do in our 50s or 40s, 50s, 60s, and beyond, because what we're looking for is safe, effective, health promoting longevity. We're not looking to try to make a baby. So that's where I think that's kind of the way I think about it.
Mm-hmm.
Um, and I think that's where most people have landed who do, this kind of work. So does that answer your
Right.
question or?
Yeah, no,
Yeah.
100%.
Okay.
Yeah.
Yeah. So this is interesting because too much progesterone is pretty hard to do. Like it's not something that your own body would really ever do unless you were pregnant or taking hormones or on birth control. And in that case, the symptoms are from synthetic hormones, which you tend to on birth control pill, the type of progestin, which is not a natural progesterone, they have a lot of different side effects. They can act very androgenic, like testosterone. They can act estrogen like. They can have, they can sort of run the gamut. So they do make different, there have been many generations of progestins that have been produced by drug companies for different reasons, trying to minimize the negative side effects. But this is the kind of list that I think would be helpful for patients that are on hormone replacement therapy so that they can try to figure out, and you know what, and this is in my mind. In fact, I need to like basically take these slides and hand them out to all my patients because I've been meaning to do this, is like, here you go. Here's the list of too much, too little, too much, too little. So that if you start feeling funny, you can call me and say, you know what, Dr. Sadaty, I think I have too much progesterone. What can we do about that? And so this list is super helpful if you're on hormone replacement therapy or hormone balancing therapy. Because then you might, some months you may need more, some months you may not. especially in perimenopause, you might have a great ovulation one month and not need that progesterone, or you may have an ovulation that doesn't even happen, in which case you need more. So this list is great for patients that want to just be aware, like, am I on the right amount of progesterone?
Right. So, I mean, let's just talk about this for a minute, because there's things on this list that are on the estrogen list, right? That are going to be on the testosterone list. So, like, when you're going through this roller coaster, how do you know? I'm having a headache this month. Is it my estrogen? Is it my progesterone? Like, how do you really know, even if you're on hormones?
Yeah. So the one thing is, if you're having periods, when in that month are you experiencing these symptoms? So if you're
So timing is really important.
It's very important. So if you're
Okay.
experiencing symptoms in the first 2 weeks of your period, so just so everybody knows, when we talk about a cycle, day 1 is the first day of your period. In a 28-day cycle, which average, day 14, between 12 and 14 is when you ovulate. And then when you ovulate is when you make your progesterone. And then if you don't get pregnant, the progesterone goes down, and then you'll get a period again. So then you start back on day 1. So the first 2 weeks of your period, you do not make progesterone. You haven't ovulated. So there's kind of no such thing as too much or too little progesterone, because you're not supposed to have any. What you might have is too much or too little estrogen. In the second half of your cycle, when you do make progesterone, that's when too much or too little kind of makes sense. And you sort of want to see, okay, where are most of my symptoms in that cycle? Now, because there is a lot of overlap, I'll use things like, well, what is your period like? If it's super, super heavy, you probably have too much estrogen or too little progesterone. So there are other signs that, you look for. Are you having vaginal dryness and hot flashes? Because that's a too little estrogen thing. So a little bit you want to look at the groupings, a little bit you want to look at where are you falling in your cycle. But in some cases, it's hard even for me to figure out with patients. And then I just have to kind of guess my best. Like, I just have to use my judgment and play around and say, okay, you know what? Let's try this month and see how you do. I think your estrogen is too low. Let's try this. So it's a little like you're very right. These symptoms do overlap. But if the preponderance of things are under one category, and depending on where you are in your cycle, that's how we can sometimes figure it out if it's not clear. Because
Okay.
it's not.
We're going to add a chart. We're going to add a chart to the slide.
A Venn diagram.
Right. Yeah. Like, I'm picturing like a color wheel.
That's what we should do. That would be good.
Okay. We'll add one to the slides before we send
We'll
it
make
out
that
to
next
people.
time. Yeah.
Okay. Okay. Not enough progesterone. And this is, I think, what, if you're dipping in the progesterone world, these are the things that you're going to feel, which I've been there.
Yeah. So I think the biggest thing that people should take away from this is this. If you start developing palpitations in your 40s and 50s, try some progesterone before you think you have a heart attack. Certainly, get your heart checked or whatever. 99 times out of 100, it's you lost your progesterone. I have so many patients that were sent to the emergency room because of palpitations in the middle of the night, EKG, echo, cardiac enzymes, blah, blah, blah. And I'm like, darn, I wish I'd known. I would have put you on progesterone. Like, it's such a almost sine qua non of low progesterone is heart palpitations in the middle of the night, and panic attacks and anxiety. Like, those are low progesterone symptoms. I actually just wrote a blog post about hormones and mental health, because the rates of new diagnosis of anxiety and depression, well, in women are threefold higher than men, but they're also much higher in the 40s and 50s. And a lot of times when patients are on antidepressants, and either they might have worked initially, but now they're not working anymore, look at your hormones. Like, that's probably your problem. And if you fix that, your mood will get better and you won't need those medications. But at any rate, the low progesterone is a huge issue in perimenopause. So this is where supporting with progesterone is so simple and it's so helpful. So, here's the situation where you don't necessarily need any estrogen, you just need progesterone. And
I think that's a really powerful statement, because I think a lot of people that have the fear of doing hormone replacement therapy is because of the estrogen component to it. And I'm only on progesterone and testosterone. People are like, what do you mean? How come you're not on an estrogen? And it's like, I don't need estrogen.
You don't need
I'm
it.
actually too high in estrogen. So you can do HRT without having to take estrogen. And I think estrogen is one of the fears, because that's the one that everyone ties to breast cancer. I mean, I think that's a true statement, right?
I think there's a lot of fear around estrogen, even though, the ironic thing about estrogen is in the Women's Health Initiative, the women who were on estrogen alone, those were the women who had hysterectomies, had a lower risk of breast cancer. So it is kind of ironic that we're so scared of estrogen. Overall, we've talked about this before. So when we talk about full-blown hormone replacement therapy, we mean estrogen, progesterone, and usually testosterone. Unless you have a hysterectomy, you for sure have to have both estrogen and progesterone. I often recommend it for patients, even if they have had hysterectomies, to go on progesterone anyway, because guess what? They're having palpitations and insomnia and depression and anxiety. So why would I withhold that? Progesterone is also incredibly anti-inflammatory. So joint pains, I should have added that to this list. Joint pains get resolved oftentimes with progesterone and sometimes estrogen as well, because estrogen can be very anti-inflammatory. So even women who, quote unquote, don't need progesterone, I would, if their symptoms require it, I certainly would encourage it. So,
and to the point of joint pain, which we didn't include on the list, but I'll make a revision, which I think is really important. All of a sudden you start waking up in your 40s and you're like, why the hell do my hips hurt? I didn't even work out yesterday. Or like my elbows are sore for some reason. You start getting these random pains. You're like, oh, I'm just getting older. But it's not you're just getting older. It's that, yes, you're getting older, but these are all symptoms of perimenopause.
Yeah. No, listen, I learned all this from my patients. My patients taught me all that. I remember it was years ago, like way before I started doing any of this stuff. And this one woman, she was Scandinavian, and she was like, had asked me about going on progesterone, because she was sort of well-read and sort of a different, I think, philosophy in Europe or whatever. Anyway, she's like, I heard that if I go on progesterone in perimenopause, that it's going to help my joint pain. I was like, what? Come on. And she's like, no. I think I would like to try it. I was like, okay, let's try it, And so we did. And not only did it help her joint pain, it also helped her allergies. And I looked it up. And for sure, there is an association with allergy reduction and progesterone. I was like, oh my God. So the patients teach you this stuff, but but now I can educate my patients and say, listen, if you have joint pain and you have inflammation, whatever, hormone replacement therapy may be super helpful for you. And I would say 9 times out of 10, it is. It's not always, listen, there are a million reasons for joint pain, but it's super helpful.
I moved on to the next slide. So we can talk about testosterone, which I love.
Testosterone.
Me too.
I love testosterone. So, obviously the biggest reason that women look for testosterone is for libido, reduced libido. Also difficulty with orgasm. It's another big reason. But more and more women,
it works. I'm just gonna say
it works. It works. It does work. More and more though, women are kind of like, and my muscles are not what they used to be, and my mood isn't great, and I'm not as decisive, and I'm kind of depressed. Uh, you know, like lots of reasons. So the biggest
Brain
reasons
fog.
that I
Let's throw
like,
brain fog in there too.
yeah, brain fog. Yeah, I mean, there's definitely focus, concentration, cognitive things,
Mm-hmm.
but I think the biggest reasons that women will use it are to address sex drive, weight, orgasm difficulty, and maintenance or building of muscle, which we know is related to longevity. So the more muscle you can keep on your body, the better your aging process will be. So to lose the testosterone, which really is critical for muscle maintenance and production, is another, I mean, why? Why should we not have testosterone? So now this is something where you definitely want to measure, you want to make sure it's low. Not everybody who goes into menopause has low testosterone. Your ovary still makes testosterone up until age 64, 65. As opposed to estrogen, progesterone, ovary still makes it, which is, I think, another reason why women, when they have their ovaries removed, go through such horrible menopause, because not only do they not have estrogen, progesterone, which is bad enough, you have also removed their testosterone. Now, fortunately, your adrenals can make some testosterone, but most women are adrenally depleted. So that's like not happening either. So I encourage anyone in perimenopause who has any of these symptoms, get your level checked. If your level is in the lower 25th percentile of normal, doesn't have to be below the range, because guess what? You know what the range for testosterone for women is? 0 to 6. That's the range. Can you imagine? 0 is normal? No, it's not. So if you're in the lower 25th percentile of the range and you have these symptoms, you're a candidate for testosterone replacement.
It's been a game changer for me. Just gonna say that, and creatine.
Yeah,
Creatine was
awesome.
one of those things that, the more podcasts you listen to in this space and in the longevity space, the more everyone's talking about creatine. And it helps with focus. It helps with, getting your muscles hydrated. You are not going to take creatine and look like a bodybuilder. I just want to put that out there. That's not going to happen. And you're not going to take testosterone and look like a bodybuilder. At this age, these are the things that we need.
Yeah. Well, there definitely are. You do have to be careful with testosterone. So, a lot of people have heard of testosterone pellets, where you inject the testosterone under the skin, and it's a continuous high dose of testosterone, and some women feel amazing on it, but it is incredibly high doses of testosterone. I'm not so clear what the long-term consequences of that are. I try to be very careful with testosterone. So we start at testosterone, we check a level, we see how you feel, we modify, we check a level, we modify, until you get a clinical benefit, but you're in a safe zone. That's what we're looking for. The downsides of testosterone, if you have too much, you could get acne, you can get oily skin, you can get hair where you don't want it, you can get a little aggressive, but the idea is start low and go up slow. That's the key with testosterone. Because, if somebody gets hairy and pimply and oily and balding, they're not going to be too happy with you. So
I think your comment to me was like, I don't want you to be mad at me. I'm going to start you slow.
Yeah. Yeah. No, really. I don't want that phone call.
Of course.
So yeah, but it's a game changer for a lot of people.
Yeah. All right. Let's talk about 50s. And some people in their early 50s may still be in perimenopause, which, but
average
you progress,
age. Average age is 51 for menopause. So you could be 45 in menopause, you could be 60.
Mm-hmm.
I do have a 60-year-old who's still getting her period. Poor thing. But anyway, Okay, so blood testing. This is pretty straightforward. You want to do a follicle stimulating hormone, estrogen, progesterone, testosterone, DHEA, thyroid function. That you should do. I'm a fan of checking insulin levels and hemoglobin A1C levels because your insulin level is the first thing that changes before you become pre-diabetic, before sugar changes. It's the more sensitive marker. It goes up years before these other markers go up. So I love checking a fasting insulin. I like looking for inflammation as a baseline to see if the hormones fix that. I am also very interested in advanced cardiac panels because when you go into perimenopause and menopause, your cholesterol levels automatically go up. That does not mean you now need a statin. The cholesterol goes up because your hormones are made of cholesterol. So your body's like, our hormones are really low. Maybe we need more cholesterol to make hormones. Like it's a secondary effect. It's not because all of a sudden you have heart disease. And that's a whole other talk that we should have at some point, but
we should totally have it. I just want to chime in for 1 second and say I got my first set of bloods back that I did with you, I believe, and I was sitting in a golf cart next to a cardiologist. I'm in my late 40s, almost 50, and he saw my cholesterol levels, and the first thing he said to me, now this man was like in his late 60s, first thing he said is, you should get on a statin. And I was like, I'm not doing that, but thank you for your opinion. Right.
Anybody, I mean, I've posted this on my book. So for any woman who's on a statin for primary prevention of heart disease, so meaning you've not had a heart attack, you've not had a stroke, you don't have anything, I don't consider a family history because family history is generally like that person was a smoker, overweight, diabetic, hypertensive, stressed out beyond belief. So I don't consider that a family history. It's all lifestyle. But if you are on a statin or were prescribed a statin, having never had a heart event, I would highly recommend you read the book A Statin-Free Life by Dr. Asim Malhotra, who's a cardiologist from England. He goes over the data. It makes no sense. There's no data really to support primary prevention in women of statin use. None. And there's downside. There's dementia. There's muscle wasting. There's a lot of downside to a statin. So you better make sure that it's a very helpful intervention for you. So, for anyone out there, please read that book yeah. Anyway,
what you said before that, I think is so important, that the whole family history situation is, and it's not just about cardiovascular family history. People are going on, other drugs because, somebody is, diabetic in their family. There's different types of diabetes. They could be diabetic because of lifestyle. And I think that is the other side of this is, just because somebody else in your family was diabetic doesn't mean that you're going to be diabetic. Just because somebody else in your family has Alzheimer's doesn't mean that you're going to have Alzheimer's. Again, Alzheimer's is what, type 3, they're calling it type 3 diabetes now, right? Because it's all about sugar and insulin resistance.
These are all lifestyle diseases. I mean, according to my genetics, I should be obese and diabetic and hypertensive. No, I'm not kidding. That's what it said. I mean, I'm not any of those, but your genetics are not your thing. Like genetics are, that might be what you're predisposed to. That's not what's going to happen depending on how you live your life. So when somebody says, Mom, my father had a heart attack when he was 50. Okay, let's dive into that. Was he a smoker? Yeah. Okay. That's why he had a heart attack. Was he hypertensive? Yeah. Was he diabetic? Yeah. Was he sedentary? Yeah. Was he obese? Yeah. That's why. It's not because of your genetics. So you really have to, I hate that. I hate that when people say, well, your family history, you should go on a statin.
Right.
Okay.
Well, can I ask a sensitive question here? What about family history of breast cancer? Should you avoid HRT because there's a family history of breast cancer?
That's up to the individual. I certainly wouldn't. I also believe breast cancer, listen, there is less than 5% of breast cancer is genetic. The
Less than
BRCA, the 18.
5%.
Yeah.
Mm-hmm.
Yeah. Now, breast cancer is really a lifestyle disease. It's sugar, it's diabetes, it's obesity, it's toxins, it's low vitamin D, it's stress, it's inflammation. I mean, this is what causes breast cancer. Being a woman, you're like, genetics or not, you have a 1 in 8 chance if you live long enough, right? So I'm not saying that family history shouldn't play a role in sort of being cognizant of it, but what most people translate that to be is, okay, I'm just going to get mammograms every 5 minutes and MRIs every 5 minutes until I find the cancer. Like, what? So you're looking for the cancer, but how about you prevent it? What are you doing to prevent the cancer? So let's say you have a really strong family history. Let's even say you have genetics, like you have a BRCA gene or you have whatever. How are you going to prevent it? What can you do to change your genetics? That's how I think people should talk about it, and not like, let me get a mammogram every 5 minutes and an MRI every 5 minutes so I can find it. Well, how about you don't get it? How about you don't even get it? So that's how I wish people would think about it. So, and if you want to be like specific about family history and hormone replacement therapy, you're at higher risk for breast cancer if you drink alcohol. So how about you don't do that and go on hormones? So that, because truly alcohol intake is a much higher risk factor for breast cancer than hormone replacement therapy is by a mile. But nobody says that because that's not socially convenient, But anyway, that's like off topic, but like just for breast cancer, I think family history would not, in my mind, be a contraindication to doing hormone replacement therapy, because family history, I think, is the lifestyle really matters. So if your lifestyle is very clean and you're doing all the right things, I don't think your risk would be any higher than somebody who doesn't have a history in their family. That's what I think. It's, that's a consent conversation. Let's look at all the benefits and what are your actual risks? You can actually make a calculation of your breast cancer risk and say, okay, well, how can I minimize my risk? What are the things I can do in that regard? And what are the benefits to me for hormone replacement therapy? And then you have to decide, well, what makes sense to you? What feels right for you? Mm-hmm. If breast cancer is just, you're just so scared out of your mind and you would never be comfortable doing hormone replacement, don't do it. Don't do it. Like, you got to do what you can feel comfortable with. But I have women who have breast cancer who go on hormone replacement therapy, because they feel so much better. So everybody's different. Everybody's different. That's a hard conversation. Breast it's very touchy, but I think the risks are not as bad as people think.
Right.
Anyway, somebody mentioned in the chat, what is a test for inflammation on blood work? The two tests are ESR, erythrocyte sedimentation rate. That's cute. And HSCRP, high sensitivity C-reactive protein. Those are the two tests that I check for inflammation. Those are excellent, because if you have positive inflammation, you have work to do. And you got to figure out why am I inflamed? Where is this coming from? So that's what. And that doesn't mean go on turmeric. That means figure out why you're inflamed, I love when people say, what can I take for that? I'm like, I don't know. Let's figure out why that number is the way it is first.
Right. And then you can take something. One of the things that's on this list here in terms of other considerations that we've talked about, we didn't really get into detail on, but there was a question that was sent in about bone loss in menopause, and things that can be done to help bone loss, which starts to happen, yes, at a very rapid rate during menopause. I will chime in just because I know from a lot of the research I've done that strength training is a great way to start reversing, and you can reverse osteopenia.
Oh yeah,
Right.
absolutely.
So
Um,
strength training is a great way to do that.
so I think, bone loss is an inflammatory disorder. So,
Hmm.
um, all the things that can lead to inflammation in your body increase the activity of the cells that break down your bones, the osteoclasts. That's how a lot of these osteoporosis medications work. They inhibit the ability of these osteoclastic cells to break down bone. But understand that the reason that the osteoclasts are there even is because they have to remodel the bone. They have to fix crappy bone. So inhibiting that is not necessarily giving you healthy bone. But when I think about bone density, the main things I like to cover, obviously hormone support, testosterone, estrogen, progesterone, DHEA. Clearly, vitamin D levels, optimizing vitamin K2, which is arguably even more important than vitamin D because that gets the calcium into the bone, increasing your magnesium because that's part of the bone matrix, and calcium through your diet. I'm not a huge take gallons of calcium kind of person because calcium is one of 3 minerals that can be a little toxic. Calcium, iron, and copper. Those minerals can be inflammatory. So I don't love throwing tons of calcium onto anybody. But so I look at those vitamin markers, hormones, strength training, inflammation, blood sugar control. Those are the things that I want to optimize the most. And then,
Great.
And then there's a lot of other things that we can use, but yeah, those should be definitely addressed.
Mm-hmm. Let's talk a little bit about treatments that we outlined here, because I think a lot of these are important, in addition to the strength training, the, nutrition plan that you could recommend for people.
So, we kind of talked about how the pillars are the most important thing, making sure that you're optimizing sleep, making sure that you are fixing your stress levels, making sure your diet is anti-inflammatory. Very important to prioritize protein as a round number. I tell people, think about 30 grams of protein per meal. And then if you do way more exercise, you need more than that. Protein is highly important in menopause, as is strength training. Let's say that you're someone who's not interested or cannot for some reason, or chooses not to do hormone therapy. All of these other lifestyle things become way more important. It's really important to optimize all of these things, not just to help your symptoms, but also to reduce cardiovascular disease risk, bone loss, brain health, all of those things. The more you're optimized with your lifestyle, the less likely you're going to take a hit for not doing hormones. Now, in our list, we have adrenal hormone balancing. So before I was more of an advocate for hormone replacement therapy, I used to do a lot of adrenal programs because the top 5 symptoms related to adrenal imbalance are weight gain or weight loss resistance, fatigue, anxiety, depression, hormone imbalance symptoms, and gut issues. Those are the 5 symptoms, the big 5 symptoms related to adrenal imbalance. So I used to love to test for adrenals, and I used to do programs to fix adrenals. So that will restore a lot of health, and it can address a lot of menopause symptoms. So that's where doing a Dutch test comes in. And when you have the Dutch test, you have very specifics about what your adrenals are doing. And then you can support your adrenals with herbal formulas, with adrenal hormones, nutrients, and balancing out lifestyle. So for someone who can't really do hormones or doesn't want to, let's say, checking the adrenals would be a huge benefit. That sounds about right.
What?
Tests to consider.
Oh, yes.
So postmenopause and menopause are kind of the same, right? Once you go into menopause, you're a year of no periods, no hormone production, then you stay that way. So postmenopause is sort of the same as menopause, honestly. I think it's just that by the time you hit your 60s, you're less likely to have symptoms related to the classic menopause symptoms that we think about. But if you are just now sort of embarking on your journey in terms of improving your health or looking for more holistic ways or more natural ways to improve your health, then getting a baseline on these types of tests would be helpful. Blood testing, Dutch testing, bone density, cardiovascular health, like where are you in all of this stuff? Cognitive function, there isn't necessarily a test for that. I mean, there are some tests that check for dementia that you can take, but I find that the bar is really low with those tests. Like they're not looking for much cognitive function before they say, because they're really looking for dementia. They're not looking for mild cognitive changes. So I don't think these tests are particularly helpful or sensitive for a normal person.
Sorry, I was just going to say the other thing that is interesting to consider, even in your 60s, post-menopause, is a continuous glucose monitor. Having been a proponent of those I wore one on and off for 2 years. It had the biggest impact on my life.
Oh yeah.
Yeah. So,
I agree with you.
Brian and I are thinking about we did a small group program like a year or so ago, and we're considering doing another one where we just bring 15 people together. Everyone wears the glucose monitor at the same time. We had a nutritionist that was part of that group with us, and she came in and did weekly talks to the group. And it was, again, such a dork. It was a whole lot of fun. Just being able to, share results, talk to other people about what they're seeing on their monitors, sharing recipes and different things that are low sugar, low glycemic, and what won't spike your blood sugar, and different tools.
It's so instructive, and it's like a science experiment for everybody. Because everybody's different, right? Like what you could tolerate is very different than what Brian could tolerate, and just
Yeah, that was really the most interesting part of the things that he just did that spike him that don't spike me.
Yeah. It's so interesting. Definitely worth showing.
Yeah. We have one more slide, and then there are some questions in the chat that we can jump into. So I think we talked about most of this, actually.
I think this is a little, kind of, so we could go to the questions.
Right. So someone said, let me just scroll up here a little bit. We talked about the test for inflammation. What kind of creatine do you recommend?
I personally like Thorne Research, and I like Clean, Klean creatine. I'm definitely a fan of that because it has not just muscle benefit, but brain benefit and recovery benefit. It really does so much. The one thing with creatine is you might want to start slow because it can sometimes cause bloating and diarrhea. So you want to start low and then kind of become accustomed to it and work your way up. For most women, you want to aim for between 3 to 5 grams a day. That's usually the sweet spot. And if you do more intense workout, then you might want to do more. If you're looking to build more muscle, you could try to add more to help you there. But 3 to 5 is usually normal for most women.
And I would say for muscle maintenance, that's a great number. I take Momentous. We're a Momentous family. We order a lot of supplements from them also. And I 100% agree. For me, initially, I didn't like it. I started it, stopped it because I felt bloated, and I looked bloated but I went heavy. I just jumped right in. I'm like, yeah, scoop for me too. And then I tapered into it the next time around. Now I don't miss a day, and I don't see any of that bloating anymore, but I feel great.
Yeah, that's a caveat. for some people.
Yeah. Yeah.
This question, if I no longer have a thyroid gland, can I still get pregnant? Yeah, you can. I mean, you just have to balance your hormones. You have to get appropriate thyroid hormone support. And, there's tricks to that because the thyroid hormones are very important for fertility. So you want to make sure you're doing a complete panel.
Mm-hmm.
Do you find some people are very conservative when it comes to their breast tissue? I'm not sure what that means. What do you think that means?
I don't know. I'm not sure either.
If you can clarify that question. Yeah. How long can you stay on hormonal pellets post-menopause? So I don't use pellets. As I said, I have a little concern with the fact that in general, the serum levels achieved with pellets are super high. They're supra physiologic. So I'm not really sure if there is even any data long-term with pellets. I'm not necessarily opposed to them because there are some women who have tried other things and it's not been helpful, and the pellets have been really life-changing for them. But safety, I'm not aware of the information for that. Let's see. Is a range below 100 on DHES not good for even 50s? That's actually a goal. Like with DHEA is an adrenal hormone. Has a lot of, it can actually convert to estrogen and testosterone. So therefore, that's why patients that have very intact adrenals oftentimes don't even go through a menopause. Like they don't really get those symptoms if their adrenals are really intact. But if I'm, let's say, supporting someone's DHEA level because it does help with muscle, it helps with pain, it's good for autoimmune disease, it's helpful for inflammation, it helps bone development. So there are a lot of good things with DHEA. I will aim for a DHEA in the 100 level for someone in their 50s because it does decline, but that doesn't mean that's great for you. It does naturally decline as you get older. So the Dutch test is dried urine testing for cortisol hormones. I think the test it's from Precision Analytics, right? Mm-hmm. So that's a urine test. It costs about $350. It's a dried urine test that you collect on paper. You send it to the company and then they submit the result. It's like a 10-page report. It goes over what your cortisol levels are, your rhythm, whether or not your total cortisol levels are normal or too low or too high, where your DHEA is. It looks at estrogen, progesterone, testosterone, DHEA levels. It looks at how you're processing estrogen to see if you're processing them in towards a more toxic estrogen pathway, which can mutate DNA. It looks at the way you're methylating, which is one of the steps of detoxification that's very important for hormones. And it also gives you a small organic acid panel, which looks at sufficiency of B vitamins, presence of glutathione, which is the master liver antioxidant. It also has one marker for gut health, looking for dysbiosis. And it has a small neurotransmitter section looking at your dopamine, adrenaline, and serotonin. I don't really believe that those are accurate, but it's on there, so why not? 2 months into HRT, Dutch test can still be done, correct? Yes, just need to stop them prior. I wouldn't stop them. I would want to know what your hormones are doing what your Dutch test looks like on the hormones. Because if you stop
your body's
them,
processing them, right?
Yeah, exactly. I wouldn't stop them because they'll obviously show you're in menopause. And so what? You're not getting any information out of it. I would 100% do the hormones if you're on it. To clarify, if bioidentical is tried, it may change breast tissue on mammograms. It can, because you're adding hormones and, your breast is hormonally sensitive. But to be honest with you, I don't see a lot of changes on mammography. I don't have patients that go on hormone replacement therapy and all of a sudden their mammography looks completely different. That is not a theme that comes up. So, and again, because A, we're on the appropriate dose of hormone, and B, I have everybody who takes hormone replacement therapy, I want them on DIM detox. So, and DIM detox helps to reduce breast density. So I don't see that. How long after you start HRT should you repeat a Dutch test? So you can do that at any point in time. Once you're on a normal, or once you're stable on your hormone replacement therapy, meaning you feel good, you're not having side effects, like things are sort of, you're on coasting, then you can check it at any time. So I would say if you wanted to check it as soon as possible, then you would check it 4 to 6 weeks after starting. I think it makes a little more sense to start it more like 3 to 4 months later, just because your body gets a little bit more chance to kind of equilibrate with what you're taking. And you don't necessarily reach steady state with your hormones until about 6 or 8 weeks later. So I would be a fan to wait maybe 3 to 4 months, but you could do it as soon as 6 weeks or something.
All right, if you're still on this chat and you're interested in a Dutch test, just write a yes in the chat, and maybe we'll get that Dutch test group going for one of our future calls. We are way over time. I just want to thank everybody for staying and listening to the entire thing, 30 minutes over. Thank you very much for your time, Dr. Sadaty. I learned something new in every conversation, so I really appreciate you taking the time to do this. This has been great. And thank you, everyone, for showing up and for being here. Keep dropping your yeses in there, and maybe we'll get that Dutch test group going for the geeky ones here that want to do it together. We're getting a lot of yeses.
Awesome.
All right, excellent. Well, thanks, everybody. And we will send out the recording and the slides if you are here, and even if you signed up and could not make it tonight. So thanks, everybody.
Thank you, Hayley. That was a lot of fun.
Thank you. That was great. Thank you. Bye.
Bye-bye.